Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be an interesting and important session covering a very interesting question. If I use egg donation, will my baby look like me? Now, egg donation is a big topic, and I think we'll have lots of questions around egg donation generally, so we'll definitely cover those other ones as well. Egg donation is a big step for most women, and it's not usually their first choice. So given the cost and emotional investment required, it's important to be aware of all the facts. I'm joined tonight by a fantastic set of panelists who are here to help you better understand egg donation in general, and specifically, will my baby look like me? They are Dr. Konstantinos Pantos, Medical Director of Genesis Athens in Greece, Dr. Katharina Spies, Medical Director of Vida Fertility Institute in Spain, and Dr. Hana Visnova, Medical Director of IVF Cube in the Czech Republic. I'll start by asking each of our panelists to introduce themselves and their clinic with an emphasis on the provision of egg donation services. So if we can keep that quite brief. And after that, I'll ask them each a fundamental question to give an overview and a brief introduction to tonight's topic, so we're all on the same page. And then we'll answer your questions that you've sent in. So thanks for that. I'm hoping we can cover what you as a patient can do, what the clinic can do, and the relative importance of each. If I can ask you please to put your questions in the Q&A box on the right-hand side, not the chat, that will help us to deal with all of them. We'll try to answer all the questions, but I'll prioritize the ones that are easy to generalize and haven't already been answered and stick to tonight's topic, just in the interest of time. So first, can I ask Dr. Pantos, if you can just introduce yourself and give a little overview of your clinic and as it pertains to egg donation services. Thank you.
Yes, thank you very much. I'm honored to be among the panel. We have 4 clinics here in Greece, one in Athens, the other one in Crete, another clinic in Larissa, central Greece, and another one in northern Greece, Alexandroupolis. All these clinics have their own doctors. I overview them with their own embryologists. We all offer egg donation. It's one of our primary service and one of the services that we offer. And we are doing over 6,000 cycles a year. And we're also contemplating to open another unit in Santorini, one of the Greek islands, so that we can combine this with medical tourism.
Thank you. That's really clear. Thanks very much for that. Same question, same introduction, please, for Dr. Spies.
Hello, good evening to everybody. Thanks for inviting me. I'm very pleased to be here. So I'm Dr. Katharina Spies. You might know from my accent, I'm German. But I live in Spain, and I'm the medical director of Vida Fertility Institute in Madrid. Vida Fertility is quite a medium-sized clinic. So we have 2 clinics. One is in Madrid, the other one is in Alicante. And we aim to do very personalized treatments. So our aim is not to grow and be a huge clinic, but to do a good overview, know our patients, and do personalized treatment. And for the treatments we offer, well, it's everything that is allowed in Spain. So we do a lot of IVF treatments with the preimplantation genetic diagnosis, as well as egg donation treatment, ROPA treatment, which would be between 2 women. And I think I'm going to explain to you later in detail.
Thank you very much. And finally, Dr. Visnova, if you could give us a little bit of background about yourself and your clinic. Thank you.
Hello, good evening, everyone. My name is Hana Visnova. I'm the medical director of IVF Cube clinic in Prague. Our clinic is very similar to those clinics what my colleague introduced earlier. We can offer you all kinds of IVF treatments, including egg donation, including genetic testing of embryos, but in comparison to Dr. Spies, we can treat only heterosexual couples in our country. And the egg donation is a very huge proportion of our treatments.
Perfect. Thank you very much for the introduction from everybody. That's really useful to give the listeners a kind of an overview because they may want to contact you directly later. So now we'll start with a few basic questions. We will get to the audience questions in a second, but can you very briefly? I'm going to start. I'm going to stay with you, Dr. Visnova. Can you give a very brief overview of what preparation a patient would need to do for an egg donation cycle, please? Just the steps so that we're on the same page.
So first of all, they need to take the decision, because this is a very difficult decision to go the egg donation road. So once they agree with the partner that this is the method of choice for them, they need to get in touch with us, and we make a short consultation to summarize their medical history to be sure that they can do such kind of treatment. And then we ask them to submit different hormonal results, ultrasound pictures, and from the beginning we also ask the male partner to arrive to Prague to give his sperm sample, and then we start to choose the donor for them. We provide them with a donor questionnaire to match an appropriate donor, and once we find a donor suitable for them, then we issue the treatment plan for the recipient.
That's great, thank you. That's really nice to get all those steps, and I realize there'll be slight differences between different countries and so on, and we can cover that later if needed. So Dr. Pantos, I'm mixing up the order on purpose so we don't do the same people in order. What steps does an egg donor have to go through to be eligible to donate? So, you know, from someone saying, I'd like to donate my eggs, through to becoming a donor, just very briefly, please.
Can you hear me? Yes. She has to be under 35 years of age. We do take a medical history from her for the egg donor. We family history also. We do prefer donors who have had a pregnancy in the past, and also who have no health issues, and have no other health problems. She has to consent, of course, and here in Greece the law allows up to 12 children per donor, which does not include overseas patients, just for Greece.
Perfect, thank you. These are really beautifully concise answers. I love them. Thank you. So, Dr. Spies, how does a patient go about choosing an egg donor? And I realize it'd be different for different patients in different countries, but you know, what are they choosing from if they come to your clinic? What's the offer?
Okay, so in Spain, egg donation treatment is anonymous, so the patient can't choose the donor, but we choose the donor with the physical characteristics of the patient and of the couple. So what we do is we ask them to send us some pictures to complete like the phenotype characteristics, and with this we get a meeting every week between the doctors, the biologists, the nurses, and we choose from all our donors which we have, which are able to do donation in this moment. We choose the best donor for each patient. So it's mainly the physical characteristics. We can also choose the blood group. So this is something we offer. And more and more, we are now also choosing with immunological issues. So in patients with implantation failures or with repeated miscarriages, we do the KIR and HLA-C testing. We talk to immunologists, and if necessary, we choose a donor with a specific HLA-C for the patients. But I have to repeat that patients can't choose the donor, so they will never see a picture. They will not get this information of the donor. They will just get the age and the blood group.
Okay, do they get the information about whether the donor has produced children before or not?
We are not allowed to tell, but we can include as well proven fertility for the patients. If patients demand it, we can choose donors which already have children on their own, or who did treatment with other patients, and we had an ongoing pregnancy out of it, or we had euploid embryos out of it. So this is something we can respect, but we're not allowed to tell the patient.
Okay, perfect. That's really clear, and I'm sure I'm going to go to the other doctors because I think we're going to get slightly different answers, which will obviously be helpful for people listening to know. But I will do a slight follow-up question because I think you're going to give me a very short answer. Given that you the clinic do most of the choosing and matching, the question, what could I do, patient, to increase the chances the baby will look like me, is the answer in your case not very much.
You have to trust the clinic to send us a good selection of photos, which is also important. We normally ask for photos from now, from when the patient was a teenager or a child. And I always tell my patients, you can describe me your ideal donor and I will look for her, but I can't give you pictures. So
Okay.
it's a very, in Spain it's true, it's anonymous, but it's true that also the clinics are aware of this and really try to choose the best donors with the physical matching for the patients.
Okay, thank you. That is super helpful, and I know Spain's very well known for doing egg donation, so I know the system must work. To keep moving things along, I'm going to ask Dr. Visnova to answer the same question, but starting with that, how does a patient in your clinic or in Czech, you can generalize it a bit more, go about choosing an egg donor? And please try and highlight the differences that we just heard, from what we've heard, and if there are chances to increase the chances of the baby looking like the patient.
So first of all, I need to confirm that we can do also anonymous donations as well. So in our country, open identity programs are not allowed. So as Katharina said, the patient must trust the clinic. They send us a questionnaire as a donor matching form. They can request, for example, proven fertility or blood type match. What is probably different in our country, we have a mandatory genetic testing of all donors, what my colleague have not mentioned. So we need to run genetic tests for the donors first. And on top of it, our clinic offers also additional tests of genetic compatibility between the male partner of the recipient and the donor to eliminate the most frequent genetic conditions. And we are not allowed to show any pictures of the donors. We can disclose just basic characteristics of the donor. I can tell the couple if she is a proven donor. I can disclose her age, her blood type, and of course we try to follow the phenotype criteria. And as Katharina said, we ask them if they agree, they can send us their pictures from their childhood. I always recommend them to submit pictures at the age approximately the same as is the age of the young donors, to send us some pictures when they have been in the middle of 20s or early 30s, because every one of us is changing in our lifespan. And on the other hand, if someone is asking me the question, will my baby look like me? Then I usually tell them, you never know. Even if there is a natural conception, you never know how the child will look like. There are so many combinations. And sometimes you find a similarity with an uncle from second generation, so you never know. And on the other hand, I believe we have beautiful children, and mostly the children, because if they grow up in the family environment, they copy a little bit the mimic of the parents, and if they share similar activities, they can, let's say, they can get some similarity in the way of behavior, in the mimics, looking a little bit like the parents, the social parents, not the genetical parents.
Okay, thank you. Really helpful. Dr. Pantos, same question. How does someone pick a donor in Greece and specifically your country?
Okay, yeah, we we have recipients who come from Greece, but we have recipients who come from other countries. I've counted the countries, and there are over 67 at the moment, countries from which patients are coming from. So we do a lot of Skype consultation. Here in Greece, it's anonymous, as in the other countries, but lately this has changed. Since last year, it's also known donor. There's this category of known, which has to be relative at the moment, a relative of the recipient, and have the known donor. But in soon enough time, I think this will change, because there's a lot of discussion of opening it up to known donors. So there are going to be two categories: one, anonymous, whoever wants to have an anonymous donor, and known donor. A woman can bring her friend, her relative, or whoever is under 35 years of age with no health issues. They do the tests, the infectious diseases and genetic tests also. There are a variety of genetic tests that we do, like thalassemia, cystic fibrosis, SMA, and depending on what people might like. In the anonymous donation, of course, they cannot see pictures, but they can get profiles. So what we do is we provide a number of profiles, and the recipients choose the profile that they will like, which they feel more comfortable. The children, it's amazing that at the moment the vast majority do look like the mother, and it sort of gives me an impression that they take some characteristics from the recipient also, in one way or another, one might think. But yes, this is how the situation is Greece. The recipient here can be up to 54 years of age. Less than 54, she can go for donation.
Perfect, thank you. Lots of really useful information there. And to the other docs, if you want to throw in what the age limit, when you're next answering a question, throw in your age limit or anything you've heard that is specific to your country. That would be really useful. So I'm going to go back to Dr. Visnova on this one, and I'm going to sort of generalize it a little bit. Let me put the question up. So this is about, does using an egg donor, or it must be to do with using an egg donor rather than the process itself, does it contribute to autism? So, if you can give a sort of brief answer on that. And actually, if I can open that question up a little bit more and say, are there any risks using an egg donor that are, that's more of a risk than using your own eggs? Because I think that's what that question's getting at.
I don't think so. I have not heard anything about any correlation between egg donation and autism, but there are some theories that the male age may contribute to psychiatric disorders, and because the egg donation, the recipients, they sometimes have a male partner in really advanced age in comparison to general population, there might be a risk contribution of the male partner as well. And on the other hand, I believe that the egg donation from the safety point of view is better as own egg treatment at the same age, because the young donors are really young. There might be 15 or even 20 years, or in Greece maybe even younger as the recipient. So the risk of genetic abnormalities like trisomies is decreasing. And also, as what we said a few minutes ago, the donors undergo genetic testing. So they are actually better investigated as the general population prior to the donation.
Perfect, thank you. And what's the age limit for using an egg donor in Czech?
In Czech Republic, we have a strict age limit of 49. So after the birthday 49, they cannot approach the treatment here anymore.
Okay, thank you. That's perfect. I'm going to go to Dr. Spies now because you mentioned it in your introduction. So can you, and there's a few questions on it, so I rather than ask all the questions independently, can you say a little bit more about the immunology testing that people can have, and what's significant, what isn't? So this is what somebody's asked. What's the KIR and HLA-C testing you mentioned, but also someone's put something in about DQ alpha, if you want to cover that as well, because I think that's relevant. And if I see anything else, I'll ask you. Okay, thank you.
Perfect. Perfect. I just wanted to add before I answer this, that of course in Spain, the donors are also tested in the genetically issues. So we also test the same mutations as you mentioned. It's also in Spain. I just did not mention it before. So we also do genetic compatibility tests. So the KIR and HLA-C is something I would say quite new. And it has been raising in the last 4 or 5 years maybe. So this is a test which we can do on patients who do IVF treatment with their own eggs, or if we include egg donor, sperm donor, etc. And we normally start to use it if we suspect or implantation failure, or if the patients have repeated miscarriages. This is something that we add now for these complicated cases to say. So what we do is for the patient, we test the KIR, it's KIR, and the HLA-C. For the male partner or for the sperm donor, we also test HLA-C. And then we look if we see that there is a high risk of rejection or possible rejection versus the embryo. This is normally in a KIR AA. There are 3 types: KIR AA, KIR AB, and KIR BB. So in the KIR AA patients, we have to be careful, and we have to check if we maybe need a donor with a low C2 charge. So there we would look for a donor which is HLA C1, C1. It's very, very specific. It's something that we do in cooperation with immunologists. So we have a couple of immunologists who do not work directly in the clinic, but work in Spain, and we do online consultations with them and with the patients. And if we see that a patient might take any benefit of this, we add it before we look for the donor, because like this we can look for a donor who might lower the rejection of the embryo, and like this we improve the outcome, the clinical outcome. And the second question was
DQ alpha.
DQ alpha, I don't know.
Okay.
This is something we do not use. What we like in the immunological issues, it's the KIR, the HLA-C, and then we do a lot of testing, which is like the thrombophily studies, the leukocytes, the antiphospholipid syndrome. All this is also included in the immunological exams or in the immunological testings. But DQ4 alpha, as far as I know, it's so far not included in the tests that you demand.
Okay, thank you. And when one of the other doctors is answering, if you have an answer for that, then please include that. What was the age limit for Spain, by the way?
In Spain, there is no legal age limit, but it's true that most clinics put as an age limit like 50, 51 years. In our clinic, we accept new patients until the 51st birthday. And if in the case, imagine that we have a woman who has just turned 52, had just had a baby, and has still frozen embryos and wants to go for a second child in order to have a little brother or little sister, we accept them under specific conditions until the 53rd birthday.
Perfect. Thank you very much. Okay, I'm going to move back to Dr. Pantos now, but I'm going to ask all of you the same question because I think it is relevant for countries and clinics particularly. So this question is, let me put it up. What are the success rates of egg donation for live birth success rates? Please be specific about the success rate.
Okay.
So in your clinic and generally in Greece, and would you consider 45 the age at which someone should stop using their own eggs?
Yes, well, this is very interesting because here in Greece, we do know that as a woman ages, so do the mutations, so does the pregnancy rate go down. Now, the general consensus is 44, 45. However, me, as my colleagues also, do believe in the right of a woman to continue on to try with her own eggs as long as she knows that she's going for low pregnancy rate. So we do have lots of women who are older, 46, 47, 48. The oldest I have delivered with own eggs is 49. But these, we always stress that the pregnancy rate is quite low, lower than 5%, for example. As long as the woman knows and she wants to continue with natural egg pickup and with a freeze collect policy, a number of women have been able to conceive. However, we generally advise for women over 45, 46 that the donor egg option is the best option. To tell you the truth, the donor egg option is the best option for all women, even over 40. However, very few women will go, here in Greece at least, as a first attempt for donor eggs unless they have done several attempts with their own eggs. And I think this is psychologically good also, that they will understand that they have tried with their own eggs before going to donor eggs. They will accept this much more easier. However, we do not put a strict age limit for their own eggs. I mean, we do not say, oh, you're 45 plus, one day we will not treat you. We do treat as long as they know that they're going for low pregnancy rates.
Okay, and the rough idea of a success rate for a 45-year-old using donor eggs?
It's about 15%. 15%. However, we cannot put all women in the same basket. It's a different pregnancy rate if she has low endometrium. It's a different pregnancy rate if she has good endometrium. It's a different pregnancy rate if her partner has a male factor or a non-male factor. It's different if she has a higher AMH and produces more eggs so that she more readily gets blastocysts than some women who have a low AMH who do not produce eggs. We tend to use a lot of natural cycles in older women. It seems that we can get better quality eggs, and we do allow them to grow to blastocysts also.
Yeah, sorry, my apologies. I didn't mean using their own eggs. I meant using donor eggs.
Sorry, because the way you asked me was like donor own eggs. For donor eggs, we have a pregnancy rate about 65% total pregnancy. However, about 50% live birth. About 1 in 2 do get pregnant and reach the final stage. We are able by law to put 2 embryos in. Lots of women choose 1 embryo, but many women here in Greece, they're more aggressive in this aspect, and this is allowed by law also to have up to 2 embryos per embryo transfer.
Okay, perfect. Thank you. Same question for Dr. Visnova, but can I also ask you, I'm going to add another question in because I'm sure your success rates are similar. Lady asking about using PGTA on a donor. So first of all, do you think it's worth doing? And is there a concern with using a donor who's too young? Because she's been shown a chart. I think I've seen that chart actually, where the numbers are quite low for a very young donor, but the chromosome abnormalities seem to be slightly higher. It wasn't a normal progression to increased chromosome abnormalities with increasing age. There was like a blip at the beginning. But, can you comment on that, whether or not to use PGTA, what your success rates are like with a donor, and if you should use a donor over a certain age and, under a certain age?
So our standard approach is not to include PGTA for egg donation, but if someone, based on her medical history, is worried of trisomies, or if there is any medical condition on the male side, then of course we are allowed to do PGTA. on donated eggs as well, but I don't think it makes any major advantage, as the donors, they have been screened for genetic conditions in advance, and they come from an age group which there is no high risk of trisomies. I don't have personal experience with too young donors. In our country, we rarely see someone available or offering to donate eggs younger as 23, 25 years. But I know what you mean. There have been some theoretical studies that at very young age, let's say the teenagers have higher risk of trisomies in comparison to females in the middle of 20s, that there is like an increase in the early fertility age of genetic abnormalities, but in such young age is not allowed to donate eggs. In our country, they are allowed only when they are 18. But as I told you, I'm not sure if I have seen anyone 18 at the age of 18 coming to or being considering the idea to donate eggs. Yeah.
Okay, thank you. And ideally, would you prefer to have a donor who's got proven fertility rather than, regardless of age?
Yeah, I always prefer a female who is a mother herself, because simply the experience and the cooperation and also like the emotional feeling of the donor, those all make advantages in comparison to those who are childless or never intended to have any family.
Thank you. Dr. Spies, here's a question. It's got quite a few bits to it, but I think given that you're in Spain and what you offer, I think you probably can answer this quite well. So this is a woman's over 40, but please answer the question if she was using her own eggs or donor eggs. Should she consider more than one embryo for transfer? That's number one. We've already kind of answered this question, but it might be different in your clinic. Should she use genetic screening in embryos generated from donor eggs? If the donor's between 30, 35, youngish donor. And is it possible to choose the blood type, which I think you've already answered, actually?
Yes, so I confirm that you can choose the blood type. In the end, the blood type, it doesn't change the pregnancy rate. It does not change the success rate, but it's something that we offer to patients in order to avoid that the family or friends or whoever can know, because of the blood group of the baby, that the treatment has been with egg donation treatment. In our clinic, so in Spain, it's also allowed to transfer several embryos. It's legally allowed up to 3 embryos. I have to say that I have never transferred 3 embryos, near my colleagues, but we decide the patients between 1 or 2 embryos. It's true that our recommendation generally for everybody is to transfer 1 embryo in order to avoid the twin pregnancies, because it's true that the pregnancy chances are quite high. With egg donation, it's similar to what Dr. Pantos said. It's like 60-65%, and the success rate doesn't raise too much if you transfer 2 embryos. It raises about 10-15%, but it's true that you raise a lot the risk for twin pregnancy. I say risk, not chances, because in the end the pregnancies are much more riskier for the patients and for the babies. So normally up to 45, we give the patients the option to transfer 2. If a woman is older than 45, or if there are contraindications like former C-section or fibroid operation or obesity or high blood pressure, diabetes, anything like this, we really recommend 1 embryo, so single embryo transfer. And the other question was about the genetic testing if we do an egg donation treatment. So normally, as the donors are young, there's no medical indication for doing genetic testing in egg donation treatment, but we can do it. When do we recommend it? As my colleague said, if there's a male factor, so if there are alterations in the sperm, if they had trisomies in the past, if they had several miscarriages, or if the patients are really interested in doing it and decide. And more we also do it in patients who have done a lot of treatments already, in order to know that we will only transfer genetically healthy embryos and also raise the chances of a healthy child.
Okay, thank you very much. This one's specifically for Dr. Pantos, because I guess it's Greece specific. So we'll go to you, and then I'll come back to Dr. Visnova for a different question. You mentioned that the donor can have up to 12 children for, this person heard it as Greek families, and doesn't include overseas recipients. Is there a maximum number of children allowed for donor recipients from overseas, or a total maximum, if you like?
No, it's up to 12 children for Greece. There's no maximum number of children outside of Greece. And of course, this does not include babies within the same family. So it's actually for 12 families. I think that this is quite liberal and within the framework of our medical practice. As I said, here in Greece, we do have an embryo transfer of up to 2 embryos for egg donation. If a woman uses her own eggs and she's over 40, but legally it's allowed up to 4 embryos to put in. We usually do not put 4, we put 2 or 3 if she's over 40. Less than 40, it's 2. And of course, regarding the pre-implantation genetic screening, here in Greece, we have to have the approval of the health authority in order to proceed for genetic screening, no matter what. They usually do provide this service for women over 40 for own eggs. However, when we use donor eggs, they will not give an approval because they don't think this is warranted. For own eggs, less than 40, they will give approval only if there are lots of miscarriages or there's a genetic problem with one of the partners.
Okay, thank you. Dr. Visnova, you already mentioned this, but if you could clarify a little, because we do this every day. Can you explain what is meant by genetic compatibility between the donor and a male partner? Essentially, we're talking about carrier screening. I get that, but if you could just explain what you're trying to avoid. And the main reason is because this person says, my husband and I haven't had this explained, so all they've had is a carrier type test done. But obviously, if you can cover what carrier screening is and maybe what country they're from, if she can put that in the chat, that will give us a better answer of whether it's available or not. Thank you.
Yeah. So carrier screening is something different from karyotype. Yeah, sometimes patients, as the wording is similar, they don't distinguish between karyotype and carrier screening. Karyotype means that we check the number of chromosomal copies for each individual, which is a mandatory test for any egg donor in our country, or sperm donor as well. But carrier screening means that we can investigate the donor and the male partner for most frequent genetic mutations, which could any healthy person be carrying without having any relevant family or personal history. And we want to avoid that the sperm is carrying the identical mutation as the egg has. And we can offer testing, and I believe those people who follow our discussion today, they can find out in their home country multiple laboratories offering so-called carrier screening. or sometimes the couples have done it as a part of their previous genetic investigations because of the infertility issues. And if we are aware that the male partner of the egg donor recipient is a carrier of some mutation, we run the similar investigation for the donor. And there are different laboratories, some of them offer investigating for 50 most frequent genetic conditions. Some of them offer a panel investigating most frequent 230, 400, 600. I know that there are also genetical companies offering screening of 2000 mutations. So it just depends on the country and on the options for each patient. Yeah.
Thank you very much. Sorry, I'm just multitasking, putting in the chat that it's called carrier screening. So they've got that written down. Okay, that's in the chat. It's called carrier screening. If you Google that and look at your clinic, you should be able to find out whether they have it. That's the generic name for it.
Maybe I can add that we run the carrier screening for most frequent 430 genetic conditions, yeah, because it may different in different countries. I don't know what is the situation in Spain, but it's different in different laboratories.
Perfect. Thank you. That's really helpful. Dr. Spies, I'm a single female. I understand that EV Valencia offers facial matching technology to try to match phenotypic characteristics. Does your clinic have it? And is it a manual process? But I want to give you a little bit more in case you don't have it. What do you think it's worth having, or nice to have but not need to have? And then I've got a follow-up question for you after that.
Okay, so well, I'm sorry. In Vida Fertility, we don't have it. Why do we not have it? Because we are much smaller than EV. This is the reason. So as I mentioned in the beginning, we're like human-sized clinic, and this means that we know personally our donors, and we know our patients, and we do this matching on our own. So it's persons. It's not a computer. It's not artificial intelligence. It's us who do the matching. So we look at the face form. We look at the, let's say, the eyes, the nose, the ears, whatever the patients demand us. And like this, we look for the donors. I think this kind of matching is quite useful, but I think there is no difference whether you do it personally or whether it's a program. Probably it's just something. The difference is in the clinic size. If you have 800 donors, it's impossible to know them. If you have 100, you can know them. So this is the reason for us for why we decided not to use these kind of programs.
Perfect. And if I can add, because you've already said it, but if I can add, because I believe this, given that even if you do this beautiful phenotype matching with pictures and AI, it doesn't guarantee what you're going to get at the end. It just kind of pushes the odds in your favor. So this question was about, you get more information in the US than you do in most of Europe. So, I mean, I'm translating the question into, so is it better in the US? I think it depends. It depends if you've got the choice of donors and that luck's on your side when the genes mix around and you get the perfect combination that looks like you, which a lot of the time you won't, because it might look like your partner.
Exactly. I think as well that if it's an open donation, we have the risk that less women will do the donation. So we have less donors. And it's also something that you don't know this donor. You can see maybe pictures, you can see the description, but you don't know her. You will never meet her and you will not know her. And also if you meet her, or if they give you like an idea about that she says something, you can listen to her voice, you will not know her. And it doesn't matter, because the baby is going to be your baby. So it's going to be from you and from your partner, in case that you have a partner. And the baby, as we mentioned before, once the baby is born, a lot of things are going to be because of imitation of the mimics of the like of the gist of how we look like, how we smile, how we love, what we do in our day-to-day life. Also, if there are brothers and sisters, it's imitation. It's a lot about epigenetics as well, because it's not one baby you transfer to one patient is not going to be the same. One embryo that you transfer to a patient is not going to be the same baby if you transfer it to me or to Hana, for example. That's would be a different baby. So epigenetics are important. Imitation is important, and then of course it's important to choose a good donor with the main physical characteristics. But I'm sure that all the clinics do.
Thank you. And the follow-up question, but actually, can you just put it in the chat? You mentioned some immunological tests. Can you click on the chat and write the name of the test in, please, while someone else is answering the question? Thank you.
Yes. So the immunological tests. It's the KIR.
I'm gonna move to somebody else. So if you can just write them and don't say them, then that'd be perfect. Thank you. That's okay. Right. So this is a question for Dr. Pantos. Does the live birth rate decrease with the age of the recipient? And are the pregnancies more at risk as age increases?
In my opinion, no. The birth rates are more or less the same, up to the age of 54, which is allowed in Greece. And as far as the health concern for older patients, if a woman here in Greece is over 50, the recipient, she needs to have health authority approval up to 54. So we do not put all women into this process. We get health approval, which means that they do have to have a certificate from a cardiologist, from a pathologist, from a gynecologist. And if a woman is healthy and we do not really look at the age, we look at biological health, which is more important, and has the required prerequisites, so we do proceed, very much so, and the pregnancy rate more or less is the same. We have had even a woman having 2 or 3 children after 50 years of age in their attempt to try and increase their family up to 54. So we haven't had any complications from a woman other than what we know, that the age, that with increase in age, we have to be more careful, of course.
Okay, thank you. Dr. Visnova, there's a couple of questions on sperm DNA fragmentation. So do you offer that in your clinic? Are you happy to answer? Okay, yes. So can you answer the question as it pertains to using donor egg, please? You know, is it a good idea? In what circumstances would you do something differently? Would you test differently? Because there's two patient questions and they're quite complex sort of histories.
So we would recommend the DNA fragmentation test for those males where the previous fertilization attempts have failed, or they have been facing very low fertilization rates, or if they have repeated treatment failures using donor eggs. And of course, if there is any personal medical history of the male partner, like any oncology treatment, like chemotherapy, or working in danger environments, so they can consider DNA testing. But I don't think is necessary for everyone. But some people are interested.
Okay, thank you. Dr. Spies, what I'm going to try and combine a few questions here. So one of them says, sorry, this is before considering egg donation, but let's expand it into egg donation as well. This one's using your own eggs. Should you consider using DHEA if you're over 40 before you try egg donation? And then is there any preparation you could do to increase your chances, assuming you've got a good donor, good embryo, anything to do as a recipient in terms of medications or preparation?
Well, concerning the DHEA, it's true that there are some studies about this not to call, I don't like to call it vitamins, but about this medication. Me personally, I think it can help, but I'm not sure that it will help, but it doesn't do any harm. Yeah? So what can we expect from this? We know that in order to raise the egg quality and to raise the number we can get of eggs in a treatment, we have to take adequate doses of DHEAS. Normally, we tell the patients to take about 75 milligram per day. And we need to take it for several weeks or inclusive months. So the idea would be to take it for 2-3 months and then do an stimulation. It does not do any harm. I can't promise you that it helps. And the same for, how do I prepare for a treatment, for like a transfer of embryo with my own eggs, for transfer of embryo with egg donation? One of the most important for a woman is to have a good health, good general health. So very important is to have a good control of the thyroid function, have a good control of vitamin D level, of course the endometrium. We also check the HOMA index in order to see if there is any pre-diabetes in order to control it. Very, very important also to try to have no overweight or to try to lose weight if you're overweight or obese. This is very important. This does not quit that. Of course, we need a good endometrium. So sometimes we need to check with hysteroscopy before. We need to check if there is chronic endometritis or not. We need to check embryo quality. So in case of doubt, we recommend the genetic testing. And so for summary, it's very important to have a good general health with all the hormone levels in a good levels, and then of course genetics of the embryo and the uterus as well.
Thank you very much. And that's where I was going with that. Was there any endometrial checks? Because if you've tested the embryo, there's not so many other things. And they were talking about having some some unsuccessful rounds of IVF with their own eggs with high quality embryos. Didn't mention chromosome testing, but they were reticent about going to egg donation without checking other things first. So thanks for that. This one's for Dr. Pantos, because it specifically asks about Greece, but if anyone else has any experience, please jump in afterwards. So I think what this question is about is, do you offer mitochondrial transfer to improve egg quality? So not for mitochondrial disease. I think it's about this idea that you can reinvigorate the eggs with young mitochondria from other eggs. Do you offer that in Greece, or you personally, and what do you think about it?
Okay, there is a unit here, an IVF unit, which offers mitochondrial transfer. I do not believe that it will increase the quality of the eggs. It is done for mitochondrial diseases, as you know. However, many women, in their attempt to have their own eggs, to have their own DNA, they do seek this service. We do not offer this clinics, but I can assure you that if not all of these women, the majority will at the end go for donation. They just need to be satisfied that they've tried everything. So to my understanding, this is a good marketing tool for someone in order to try and persuade women to go to that clinic. However, because of this, we do not offer it. Women of increased age, and because we do see lots of women in the last few years coming for the first time to have a baby over 40, thinking that they can get pregnant anytime because there's not much information about how infertility comes into play after the age of 35. Most women here in Greece think that as long as a woman has menses, she's also fertile. So when they see the dilemmas and problems they face over 40, they will do anything to try and achieve a pregnancy with their own egg. finally most will end up with donor eggs. So answering to you on this question, we should be very, very careful how we handle these women, because psychology has to play a huge role in not only convincing but doing the right, providing the right medical service for all these women.
Okay, thank you very much. This is for Dr. Visnova. And if the answer is no, we don't have that provision, then we'll pass it on to somebody else. But this lady's of mixed heritage, part Indian, and they're wondering if it's possible to request, because we never used the word ethnicity so far. Now, maybe it was implied when you give your profile to a clinic and say, please back to me. So can you request specific ethnic backgrounds for the egg donor? And then this lady's half Indian, as she said. Another lady has said, do you have Japanese donors?
Yes, so you can apply for a different phenotype, but this will have an influence on the waiting time for the treatment, as most of our donors are of European origin, so having a pale skin type, and but we have some small numbers of donors coming from different parts of the world, so it might not be so easy to find someone directly from Japan or India, but if they prefer someone with Asian phenotype, we can offer them donors with originally coming from Asia, but they are sometimes not from the same region and the same like India or Pakistan or those countries. They from phenotype they look different from the general population in Czech Republic, but they in such case we don't have a huge group of donors to choose from, so the couple must be much more flexible when requiring for the treatment. They, for example, should not request the blood type much, because there might be a problem if they prefer someone with Asian phenotype to have also the similar blood type, or if they want the donor to be of the same body size or body weight. This might be quite difficult because we talk about small groups of donors which are not of European phenotype.
Okay, thank you. And I think the general point there is it's well known in the field that in Europe it's quite hard to get people of different ethnicities as donors, partly because there's fewer in the population, but also because it's sometimes more taboo to donate eggs. That's what I've read. That's the evidence I've read. Okay. Let's see. Got lots of very specific ones. Yeah, I think I'll ask everybody this one because it's quite important. You all offer, your countries all mandate that you offer anonymous donation, with the exception of Greece, which is changing. So somebody's put, is it difficult for the child in the case of an anonymous donor that it will never know anything about the donor and can never get to know her or know about their origins? Just what's your, I realize it's the law in your country, but as you know, it's not the law in every country. What's your kind of take on that? What do you think about that? Let's start with Dr. Spies. What do you think?
I think what we recommend in Spain is in order to be open with this, if patients ask us, should I tell my baby or not, we normally answer yes, tell, but tell from the beginning, tell it like something very natural, that the donor made a gift for you that allowed you to have the baby and yet to have the baby with you. And we also see it from the point of view that it's a donation. So if you have a donation of an organ or of blood donation, you also don't know the donor. So I know that this is very much personal, because it implicates a lot of things, but in the end it's a donation. So you accept this donation, and the family for this child is going to be you and the rest of the family. And if you deal with it like this, normally the children and also like the family and the background accept it and see it like something natural. It's also very similar as with adopted. You also tell, or the recommendation is to tell as soon as possible, and to see it as something positive, which allowed you to have this child with you. So, of course, it's difficult. I know a lot of German people, in my case, also struggle with it, because in Germany that's why egg donation is not allowed. But from my experience in Spain and with the different nationalities we deal with, with patients we have from a lot of countries, normally the acceptance is very good in the end.
Thank you. Perhaps because you've given such a good answer, maybe it's not necessarily that important to go around everybody. I would just say from my, personal experience, I mean my professional personal experience, that I know one lady I was working with said, I absolutely have to have the ability for my child to find out who the parent is. So she couldn't go to Spain for that reason, even though I've referred a lot of people to Spain. And then another friend who did go to Spain and is now in that situation of when to tell the child, because an important thing for the listeners, I think, is even in a country where it's anonymous, with the advent of all of these genetic tests that you can buy over the counter, there's quite a good chance that you can find out in an indirect way who the donor is because of relatedness. So it's definitely worth considering that conversation about telling your child. Whether you think it's the ethical, moral, right thing to do, I just think it's probably an inevitability as we move forward. Okay. So lots of specific questions. I'm trying to move on. Okay. Oh, yeah. Okay. So, Dr. Pantos, your donors, do they tend to be from Greece, or are they commonly from other European countries? Are they living in Greece but from other countries, or that's one of the questions that somebody's asking about.
Yes, we have to understand the Greek culture, and in that Greeks actually want, or they do not demand, but they would like and most want donors from Greece. So most of our donors are fresh donors from Greece. However, we do cooperate with egg banks, especially from Spain, where we have a multiple sort of phenotype, other phenotypes also that they might like to cover the need. Now, in the Greek culture, concerning your previous question to Katharina Spies, the Greeks do not talk about it. I mean, they do a lot of donation. They do have children. They can have children up to 54, but they do not talk about it, even though we do stress that they should talk about it, that they should be more open, they should be more sincere about this, because when a young woman, let's say 38, 40-year-old woman, sees a 50-year-old woman getting pregnant, she thinks, oh, there's no problem, I can wait. And so she delays her own fertility without understanding that these women have actually gotten pregnant with donor eggs. Even though she might herself get pregnant with donor egg, again, she will not talk about it. So this is in general for Greece. For anonymous donation in Greece, the law is that the donor cannot find, the recipient or the baby cannot find out about the donor. However, the second category, which is now coming in Greece, which is the known donor, at the moment it's relative donor, but the known donor is going to come into effect also very soon. Then they can find out who they will know from the beginning who the donor is, and the baby can know the donor too. So yes, it's all about society and the way people think and act on this, and we have to try and slowly change their point of view. I think with time.
Okay,
I would like to comment. I remember when I finished my medical studies, then even doing the IVF treatment using own egg and own sperm was a big taboo, and the patients were averse to disclose the IVF treatment using own eggs within the family. Nowadays, we are facing just completely different situation. The patients who use own egg and own sperm, they talk to everyone at work, between friends, in the family, that they undergo IVF treatment, and such taboo is gone. Is not a shame to go through IVF. And my personal expectation or opinion is that as the fertility is declining and people postpone to get families, the request to use donated eggs or even donated sperm is increasing, and maybe it will become more common to use donor eggs and donor sperms, and the taboo would not be such a big secret not to disclose to anyone, because would be better accepted that this is a medical way of donation if someone wants to have a child out of the biological borders. Yeah.
Thank you. I'm just going to answer a few questions quickly just to sort of move them on. So someone's asked about the ethnicity of donors at particular clinics. I think the best thing to do there is to just contact the clinics and with your requirement. Let's get rid of that one. And then let me just move. It's just an interesting one. I don't know if it's medically so relevant, but for Dr. Visnova, do you ask the donors their reasons for donating, and if yes, what's the most common reason given?
Yes, we ask them. Each donor must undergo a psychological interview, and we ask them for motivations. And I can confirm that there is usually a combination of that they want to help someone, like altruistic approach, combined with some other reasons. They have a friend who is childless, or they have a friend who was a donor as well, or they are just curious if they can get good eggs, and but at least half of the motivation is to help someone to have a child.
Okay, thank you. Again, I'm going to answer this one really quickly because I think it's quite a complex subject. So someone was a bit confused about the mitochondrial transfer part. So I just really want to very quickly explain it. So mitochondria are like the batteries of the cell, and it's thought that women of a older age, the batteries in their eggs are not as good. That's what it's thought. So the idea was to take mitochondria, batteries from a young egg, and just put those into the older egg. So you keep all the genetic material, but you add this mitochondrial material. But it's not as simple as that. There is a little bit of genetic material in mitochondria. And in the studies that were originally done in the US, there were quite a lot of problems doing this. So it's very much a technique in its infancy. So I hope that's explained it a little bit. And that's why it's difficult to do. And that's the potential safety issues are one of the reasons why it's not available at lots of clinics. So hopefully that's kind of answered that question. Now, we're getting to the end of our time, so I just want to ask a few more sort of generic questions for both of you, because Katharina seems to have dropped off now. I think we've already answered this one. Would you recommend PGTA for young donor eggs, but when there's advanced male age? And obviously the implication being, aside from those specific neurological conditions that increase slightly with age in males, would you expect to see an increase in chromosome abnormalities that could be screened by PGTA? So start with you, Dr. Visnova, and we'll go to Dr. Pantos. Would you offer it for advanced male age?
Yes, I agree that the male contribution is very important, and because many of these women over 40 have even older husbands. I mean, even if they're 50s, their husbands might be, 55, 60. Interestingly enough, there's no age limit for the husband, which I think that this should also change. If there's an age limit, that there be an age limit for both. But since we have older husbands, yes, they do have problems, most likely, with mutations and genetic problems. And I will certainly go for this if it was allowed, because at the moment it's not allowed here in Greece. And with the new health authority, which has just come into play, into action the last month, we're going to provide recommendations, and one of the recommendations is to allow pre-implantation genetic screening for donors where the husbands of the recipients are old or have problems of genetic origin.
So just to be clear, you're saying that you're not allowed to do PGTA for advanced male age.
Well, it's
on
allowed
donors,
with,
correct.
on donors at the moment. No, we didn't. The main reason of doing on donors PGTA is only if there is a genetic of heritage genetic problem on the husband, but not of increased DFI, let's say, or problems which have to do with oligospermia. Which I think it's not right, which should change, but at the moment it's not allowed.
Well, actually, this is a pet interest of mine, so I think it's valuable for the audience as well. I'm just wondering if someone should go on mute. Katharina, can you answer the question whether would you, I know PGTA on donors isn't a common thing, but would you do it in an exceptional case for advanced male age? I would argue, what's the evidence that there's a chromosome, an increase in chromosome abnormalities with advanced age?
Well, as I said before, the male contribution, I think, is important to the embryo quality, which will ensure from fertilization. However, we do need the license of the health authority, and the health authority will not provide a license for such a reason.
Okay, Dr. Spies, what would you say about whether it's allowed and whether you think it's a good idea? Is the evidence for it? We can't hear you. I don't know if you're on mute or try again, and I'll come back to you if we can't hear you.
Yeah, sorry.
Oh,
can you hear me now?
Yep.
Yeah? Now you hear me?
Yes.
Perfect. Sorry, yeah? Sorry, I was away. I had a problem with my computer, so I switched. You hear me?
Yes, please answer the question.
Yeah, perfect. Okay, so what we recommend is to do genetic testing, to do implantation genetic testing if the male age is over 45 or 50, because there we see that the genetic alterations raise. It's the same with women over like 39, 40. In the male, it's 45 to 50 years, and that's where we normally offer and or recommend the genetic testing of the embryos before we do the transfer.
Okay, thank you. Same question to Dr. Visnova.
Yes, so we are able to do the genetic testing based on the male age, but we recommend it to those who have low sperm count or they have some additional health issues, but sometimes the male partner is a father of multiple children from previous relationships, healthy children. So this is an individual decision, so we can do it, but we are not facing too many requests to run the genetic test. And we should explain to patients that with the PGTA we test, this is a screening, we test for most common aneuploidies, and the risk of psychiatric disorders, like someone was asking earlier, like autism or similar disorders, is not possible to be investigated or eliminated using PGTA.
Okay, thank you. I'm going to stick with you, Dr. Visnova. Just to the audience, I apologize if you're not getting all of your questions answered. There's a lot of questions. I'm trying to stick to the topic, so I'm being I'm damned if I do and damned if I don't. Somebody's saying stick to the topic, and someone else is saying you're not answering my questions. So we're doing our best, and we're trying to keep it general so we can stick to the topic. So I'm going to ask you this question, Dr. Visnova. I'm 43 with AMH 2.3, never had IVF before. They've been suggested ovarian PRP and hysteroscopy and implantation cuts, which I think means endometrial scratching, but I'm guessing. Do you think these steps are beneficial or unnecessary? And this is someone using their own eggs, but I guess some of it would be true for using donated eggs.
So first of all, I would need to know if the AMH 2.3, if she means those are picomole per liter or nanogram per milliliter, which is a major difference. If someone would have 2.3 nanograms per milliliter, then we can expect very good ovarian response despite of the age above 40. And in such case, if we perform PGT-A on embryos, we can hope to find at least one genetically healthy blastocyst. But if the female has a AMH 2.3, but measured in picomoles per liter, this gives us the prognosis to retrieve very few eggs, maybe only 2 or 3, and the chances to find among them a genetically healthy embryo are extremely low. Yeah, so this is to be explained to her, and then based on this, she can choose if she goes ahead with ONEC treatment. And she was asking also about the PRP injected into ovaries. There have been some literature data, but controversial results, and most of reports in the literature, they report experience based only on very small numbers of patients, and we need to wait for, let's say, a few years if the PRP treatment really makes any advantage or not. The answer is not known yet.
Okay, thank you very much. Right, we are nearly out of time, so I'm sorry if your question hasn't been answered, other people, but most of the ones that aren't being answered are ones that are very, very specific to you and not necessarily on the topic. But please feel free to reach out to any of the doctors or me after the session, because then we can help you more usefully. So the final question I'm going to ask to all three of you, because I think this is a general relevant question, is do you split donor eggs between recipients at your clinic? So let's start with Dr. Pantos. Do you do cohort splitting for egg donation?
No, we try to avoid this. We try to provide the eggs provided by the donor to a single recipient, so they can have more embryos frozen from the same recipient, from the same donor. So just in case they get pregnant, they can have a chance to have another child from the same donor. Or if they do not get pregnant, they can have another chance of with embryo transfer. So we try not to split. It depends, of course, on the number of eggs that the donor might produce. But our policy in general is to try and give from a single donor to a single recipient.
Perfect. Dr. Spies.
Normally we really try to do one donor, one patient, but it depends a lot on which guarantees we work with. In our clinic, or normally in Spain, we do not use guarantee of eggs or mature eggs, but we use guarantee of blastocysts. So it doesn't matter how many eggs we give you, because we guarantee a certain number of blastocysts. So if we work with a guarantee of, let's say, 5 blastocysts, it's impossible to share a donor. So all the eggs that we can obtain from a donor are going to go to one patient. If we work with like the small guarantees, for example, 1 embryo, of course, we won't use all the eggs that we can get out of the donor for 1 patient. That depends very much on this. Normally, it's 1 patient, 1 donor. We normally use fresh eggs. This is also important because this allows us to use the frozen sperm to maintain the guarantees. And then in the end, what really, really matters is the number of embryos of blastocysts that we can obtain, and this is what we work with in the guarantees.
Thank you very much. And finally, Dr. Visnova, what's your take on this question?
Yeah, so we have similar approach as my colleague from Spain. We prefer to do fresh egg donations, so we don't offer donor frozen eggs from the donor, so we don't distribute them like in a batch of 6 or 8 frozen eggs. So we prepare the treatment synchronized for the donor and for the recipient, and we, based on the response of the donor, we use the frozen, the fresh eggs for the intended recipient, and the average number of eggs what they obtain is about 11 to 12. And as other colleagues said earlier, there might be some guarantee programs that if we want to guarantee 2 blastocysts for transfer, we believe that we cannot split the eggs between a large group of recipients, because we really need for the treatment 10 mature eggs at least to hope for at least 2 good quality blastocysts, because you need always to consider the male factor as well.
Thank you very much. Just want to say a final thing about the topic. You know, we did go off topic quite a lot, which is quite common in these Ask Your Doctor sessions. And someone has quite rightly picked me up on that and said, back on the topic, what's the chance of, I'm reading as epigenetic factors influencing what the child would look like? I think the best answer I can give you is there's 2 really good articles, or two articles, one of which is mine. I'm not going to say really good. Another one that's really good on the Fertility Road website about this very topic. So I think one of them has more epigenetics in it, not my one, but I think both of those will really help you. So thank you, everybody. That's been like the most questions I think I've ever had to field in this session. Thank you so much for the doctors for giving up your time. I know you're very busy and you want to get back to your lives as well. So really appreciate your industry and efforts on this occasion. We'll hopefully see you soon on the next session. But goodbye to everybody. And if you need to contact any of us, please go through the My IVF Answers website and you'll be able to find us all there. Thank you. Bye-bye.
Bye-bye.